micro-ultrasound, what is micro-ultrasound? Well, the conventional ultrasound systems operate at 6 to 9 megahertz. Micro-ultrasound operates at 29 megahertz. And this allows visualization down to about 70 microns. Analogous to MRI, there is a Primus, not the PIRADS, but the Primus classification for abnormalities, and we'll go over that a little bit. And this does result in significant improved imaging of the prostate. You can see ejaculatory ducts and urethras and the differentiation of the peripheral zone and certain other things within the prostate. The eye-opener to me was this, an early patient of mine who had sextant biopsies prior to having this micro-ultrasound. And these were done a year or two prior, and you could see the tracks of his former biopsies. Really quite amazing. So at least you could use that to guide to not biopsy in that spot, because this particular guy did not have a discovery of cancer on his initial biopsy. This is the Primus classification, pretty hard to see from that picture, but I'll blow it up. This is a Primus 3 lesion. Here's your Primus 4, a little more heterogeneity within the lesion. This down here is called the starry sky, and that's a pathognomonic finding of the Primus 4 classification. And then you can see a Primus 5 lesion over here, extraordinarily heterogeneous and with a lot of variation, particularly in the central portions of the abnormality. Every urologist worries, oh my God, how hard is it to learn this Primus classification? And it's not straightforward initially, but the company, to their credit, has a nice online e-learning platform. They provide some on-site training. And in the studies that have been done thus far, it appears that it takes about 30 cases for an individual practitioner's positive predictive value and overall cancer detection rate to become stable. So that's where it looks like it is. Here are some of the data, and I'll roll through this pretty rapidly. This one showing that the Primus classification, like the PIRADS classification, Primus 5, a much higher probability of aggressive cancer, and you can see diminishing probability of aggressive cancer for Primus 4 and Primus 3 respectively. In studies comparing micro-ultrasound guided biopsies versus just systematic biopsies, you can see that there is reduced detection down here of clinically insignificant cancers when you only perform a micro-ultrasound targeted biopsy. So it's very similar to an MRI, where if you only did the targeted biopsy, you're less apt to discover a clinically insignificant cancer. I like this study because it shows how actually micro-ultrasound targeted biopsy and MRI targeted biopsy may in fact be complementary. And the way to look at this slide is the dark blue cancers are respectively worse. So if you do non-targeted biopsies, you can see you only find a certain number of the aggressive cancers. If you do MRI targeted biopsies, you find more of the clinically significant cancers. If you do micro-ultrasound targeted biopsies only, in this particular series, you found more of the significant cancers. If you do non-targeted, i.e. systematic biopsy plus MRI, which is probably the state of the art currently, you can see how many of the significant cancers you would discover. If you do systematic biopsy plus micro-ultrasound targeted biopsy, again, in this series, it looked like you found more of the aggressive cancers. If you had done only micro-ultrasound and MRI targeted biopsies, that actually was pretty good. But if you want to find them all in the Pokemon things, you have to do all types of biopsies, systematic, micro-ultrasound targeted, and MRI targeted. How does micro-ultrasound perform in men with a negative MRI? So this is a series in the United States, but published in European Urology, 125 patients, targeted. 47 of the men who had a negative MRI had cancer. 27% of these were clinically significant. Now, you might criticize the miss rate for most MRI series is only 10 to 15% across all of the best series of MRI targeted biopsies. So you might say that this miss rate of 27% was a little bit unusual. But I think the important thing here is that micro-ultrasound identified 33 of the 34 clinically significant cancers. Again, showing the complementarity, I think, that will exist between MRI and ultrasound. I'll just roll through a bunch of different series here comparing MRI and ultrasound, and you can see in this series 13 clinically significant cancers missed by micro-ultrasound. Another series here, 15 missed by MRI. Head-to-head comparison of the Artemis fusion platform against micro-ultrasound. You can see targeted micro-ultrasound biopsy found more cancers than the targeted MRI biopsies. Just published late last year looking at the Coelis system. Again, in this series, very similar detection by micro-ultrasound targeted or MRI targeted, and much better in any case than the systematic biopsies. This is probably the biggest series, 1,000 patients, 11 institutions around the world, in fact. And it was designed as a non-inferiority study, and that's exactly what it showed. No difference in the sensitivity, 94 for micro-ultrasound, 90% for MRI. And the negative predictive value, however, was better for micro-ultrasound than it was for MRI. If you're interested in doing focal therapy and you want to find the index or the worst cancer within the prostate, there's two series here. Neither of them actually looks good for either micro-ultrasound or MRI in my point of view, and we could discuss this later at the critique panel. Micro-ultrasound only found 3/4 of the index lesions. MRI in this series only found 2/3 of them. Not statistically different, but neither of them that good. This study from, I think it was either USC or Sinai in New York, and I apologize I didn't put the authors on here. Again, only 2/3 of the time do either of these imaging modalities identify the index cancer. So that's of some concern if you're planning to do focal ablation, and we're going to get into that later. And I will point out here that in this particular study, all of the misses, the inability of micro-ultrasound to identify the index cancer, is because the index cancer was in the anterior part of the prostate. Now, the original micro-ultrasound could only image reliably for 5 to 6 centimeters. And so that puts certain limitations on what you would be able to see on an AP view of the prostate. But the most recent iteration of the probe, as new software and whatnot, now allows up to 8 centimeters of accurate visualization. So this miss rate for anterior tumors should be less in the current iteration of the device. We had done a fair amount of this at WashU before I left, and it really shows pretty much the same thing. If you had a negative MRI, 26%. So here I was criticizing that other series because it had a 27% miss rate. Again, a 26% miss rate for clinically significant cancers, of which micro-ultrasound identified 14 of 18 in this particular case. Micro-ultrasound is in the NCCN guidelines starting in 2022, and it remains in there in 2023. Because of all the foregoing data that I presented, there is an ongoing trial called the Optimum study comparing micro-ultrasound directly to MRI. It may be a little bit hard to see, but patients in need of a biopsy are randomized to either have MRI or not. If you randomize to get an MRI, half of the patients get the standard MRI followed by targeted and systematic biopsies. If you randomize to get micro-ultrasound, there's one arm, 1 in 6, where that patient only gets micro-ultrasound targeted biopsies plus systematic biopsies. There's a middle group who randomize to micro-ultrasound who gets an MRI subsequent to that, to which the ultrasonographer performing the micro-ultrasound is blinded. And so then that patient first gets a micro-ultrasound targeted biopsy. Then the ultrasonographer is unblinded to the MRI and can then perform MRI targeted biopsies and then the systematic biopsy. So in the end, you'll have 3 groups: micro-ultrasound plus systematic biopsies in the middle, MRI and systematic biopsies on the right, and both targeted biopsies plus systematic in the middle. And that would probably be a definitive study to determine how these imaging modalities interact. And you can see there's about 1,200 patients planned for the analysis, and I've heard recently that there's about 400 patients already enrolled in this study, so it should read out pretty soon. So in summary, I would say micro-ultrasound may significantly improve prostate biopsy. I took out some of the slides about the versatility of this modality. You could do them transrectally or transperineally, because I know Dr. Olof is going to be talking about that later today. It may improve MRI targeted biopsy. In comparison to MRI, it looks like it at least has a similar diagnostic accuracy. It should have a lower overall cost because you're eliminating the costs of the MRI. It reverts the diagnostic pathway entirely back to the urologist, and it avoids the patient inconvenience of having an MRI. Some patients can't get an MRI for various reasons, pacemakers, size, et cetera, et cetera. Early data are encouraging, but are necessary to await the results of the Optimum study. So that's thanks very much. I'm sure we can talk about this more later on.